Hello, everybody. Thank you for joining us tonight. My name is Ken Rauschenbach. I'm an orthopedic surgeon here at St. Luke's Montefiore, and been here for about 20 years. I've been giving these community lectures for quite a number of years. Usually, obviously, it's in a venue somewhere around here, but the way the weather is tonight, this is going to work out just fine. I think we all have to get used to this kind of stuff for the next foreseeable future. I think we'll give this a few minutes, let people join, and then we'll get started. We're going to talk about arthritis and treatment options and go over some questions at the end. So we'll give it about 3-4 minutes and then we'll get started. So we're going to start out, what is arthritis? We use the term all the time. It's an inflammatory condition of the joint. There are about 100 types out there, and the typical, symptoms are pain, swelling, loss of motion, and difficulty doing your activities of daily living. It affects over 47 million Americans annually, and that probably is a conservative number. That's the people that have come in for treatment for arthritis, and the millions more that sit at home and deal with the aches and the pains on a regular basis. It's the most common cause of disability in the United States at this point, more than heart disease and everything else, because pretty much every one of us will develop this at some point in our lives. The typical types of arthritis are rheumatoid arthritis. Okay, that's an actual disease where the body's attacking itself. There's a whole branch of medicine that covers rheumatoid arthritis, and it's multiple subdivisions. We have post-traumatic arthritis, which is, injuries and damages our joints, and unfortunately, they don't recover completely. Avascular necrosis is damage to the vasculature to the joints, which can lead to arthritis. And then the classic, which we are speaking about mostly tonight, is osteoarthritis. This is the wear and tear. This is every single person will get it to a varying degree over a lifetime. This is, you only get your 50,000 miles on your tires, and then the treads wear out. Once they wear out, then you come see me. So it's the most common type. It's a degenerative disease that affects the joint cartilage, results from overuse, just activities of daily living, elevated weight. So there's many different reasons that lead to it, but we all get it. The most affected parts are your hips and knees. These are the weight-bearing joints, but it can come into your back, your hands. Any joint can be affected in your body. Eventually, it starts out as mild inflammation. As it erodes more and more, the contact area becomes irregular, and you can develop, all the way down to when the bone is touching the bone. This is when the symptoms become more severe, and people start to seek more and more treatment. Results in painful swollen joints. Symptoms include warmth, swelling, pain, decreased ability to move the joints, and this messes with your lifestyle. You can't do the things you wanted to do, and eventually, over time, as it gets more severe, you actually have deformity of the joints. Osteoarthritis is that wear and tear. A healthy hip has a nice ball and socket joint. As that cartilage becomes irregular, it goes from two smooth surfaces rubbing together to two irregular surfaces. Imagine, dragging two pieces of sandpaper together. When that happens, it causes an inflammatory response and eventually pain. Same here in the knees. Everyone's popped open the chicken joint and seen that nice smooth white cartilage, okay? Now, if you took a ball peen hammer to that and made it irregular, that's what you have on the arthritic knee here. And those irregular surfaces rub against each other and, again, create friction, inflammation, and pain. And over time, there's more and more damage and everything is accelerated. Shoulder, similar. All the joints are affected in the same way by osteoarthritis. What do we do about it? Initially, the best things to do are things you can do on your own. The stronger we are, the more physically fit we are, the better our muscles are working, the less stress the joints have to take. So most important thing is, light exercise. We want to keep our weight down. There's a lot of different things that affect it. Once it gets to the point where those minor things at home are not working, you come and see an orthopedic surgeon or your primary care physician. We're going to do a comprehensive history. We're going to examine your joints. We're going to do some x-rays. And then as time goes on, additional tests. This is a classic x-ray of a knee. The one on the right, you see the space between the bones is nice and even and symmetrical. That space is filled with that articular cartilage, although it's not seen on the x-ray because the x-ray will only pick up the bone. That's what it should look like. As you wear away the cartilage, that bone you can see on the other side is right up against the other bone, and that whole medial joint space is completely collapsed. You also see the spurs on the outside. It's whiter, and that darker white indicates excessive pressure, which is the arthritic component. That's what the hip looks like. The clean one on the left there, and I'm not sure if it's reversed on your screens. And on the right, on my right, we have that articular cartilage is completely gone. The bone is touching the bone, and there's no more space. And here's the example in the shoulder. Conservative treatments, what can we do on our own? What can we do before we get to the point where you have to come see me? Weight control. The more weight we have on the joints, the more they're going to wear out, okay? Puts additional stress, speeds the destruction, and impairs our mobility. So get our weight down, that's important. Exercise, low impact exercise, elliptical, the bicycle, even walking on the treadmill. Keeps the muscle strong, keeps the pressure off the joints. It can make a significant difference in controlling and delaying the inevitable, let's put it that way. Other things we can do, supplements. People with good nutritional status are going to be able to combat the wear and tear a little better. Vitamin C and D are important, so taking a multivitamin, keeping your calcium levels normal are important. The first line of defense essentially is we're treating these symptoms here, and the symptoms are pain and inflammation. We can start with Tylenol, which is a simple pain medication. More likely are the anti-inflammatory medications, which include our classic Motrin, Aleve, and Advil, etc. These are good. They work very well. They do have their downsides. You got to watch your stomach. Make sure you eat with them because they can cause gastrointestinal irritation and, in the worst case scenario, ulcers and problems. Ice, never a bad thing. If that knee is flaring up, it always reduces the inflammation. I'm not a big fan of the heat, but some people think it does well. Either way, whatever works for you, neither one are going to hurt you. The next step, if you've taken the medication, you've gotten your weight down, you're doing some low impact exercise, you come to see the doctor, okay? There's two types of main categories of injections. There's the hyaluronate or viscosupplementation injections, and then the cortisone. We've all heard of this, okay? The idea of the hyaluronate or the viscosupplementation is to kind of bathe the articular cartilage in the nutrients it needs to allow the cartilage to defend against that degenerative process. It's naturally curling substance. It doesn't truly lubricate the joint, but that's the idea, and can last 6 to 12 months, but everyone's different. Cortisone is our go-to. It's just an anti-inflammatory that's very strong. It goes directly into the joint and can last, I tell patients any day from 1 day to 1 year, all right? It's too hard to really predict. They can be used multiple times and then eventually will not work as the severity of the arthritis gets worse. A new field of medicine now is the regenerative medicine. We've heard the term stem cells for a long time, and a lot of people are interested in it. At this point in the United States, none of these are covered by insurance. These are something that are outside the realm of standard medicine. Insurance companies will not cover them. They do show great hope. We're certainly not anywhere close to being where we want to be at this point, and someday these might be the answer. For now, we have multiple types that we've been using. None of them have shown any definite guaranteed improvement. Let's put it that way. The major one is the bone marrow aspirate. That's our classic stem cells. We drain some blood out of our bone marrow. We spin it down and re-inject it into the joint. The idea of a stem cell is to be able to turn into whatever tissue it wants. When we're babies, that's the truth. As we get older, we still haven't figured out how to say, we want you to become cartilage and fill that in. So we've had some success with it, but it's certainly not something we can consistently see. Platelet-rich plasma comes from the blood. We drain a couple 30 cc's of blood, we spin it down, and we use that pseudo stem cell material to, again, help with the healing and hopefully improve our symptoms. Lipogems are stem cells derived from fat. Then amniotic cells are a newer approach. All of these things are actually getting looked at. As of October, they were supposed to, but with our COVID-19 crisis, it's been pushed back to kind of coalesce the scientific community and see where we're at as far as these types of treatments. When do you consider joint replacement? Okay, that's the end stage. That's the end game when you say, hey, I can't take this anymore. It's really messing with my life. You know, I didn't go out to dinner the other night because I couldn't walk across the parking lot. When you fail with that medication, any injections, you lost some weight, you've done the exercise, you come see the orthopedic surgeon. And that's me or one of my colleagues. The benefits of joint replacement, what are we doing it for? Pain. The number one and really only indication for joint replacement is pain control. We don't do it to make you do the jig or run a marathon. We don't do it because you can't play, full court basketball. We do it because you can't, get out to your car on an icy day, or, by the time you get through the supermarket, you have to go lay down on a couch. That's when you know you need something done. It improves your quality of life by allowing you to be active and do things. You can go back to low impact sports and just the simple things of daily living. We call joint replacement, it's also known as an arthroplasty. What we're doing is essentially resurfacing the joint and putting a new bearing surface in there to replace those damaged bone and cartilage. We also improve the alignment of the joint as well as the mobility. So again, the hip is a ball and socket joint, pretty simple structure. It moves around, goes circular, anterior, posterior, in and out. The primary components of the hip replacement are that ball. We essentially resurfacing that joint. So we cut that bony head and that irregular surface off, and we resurface the cup portion. And then you can see there's a metal ball and that plastic socket. That nice smooth articulation will take that pain away. It restores our length and our function, and hopefully our quality of life. The knee, again, the anatomy is a little different. It's more of a hinge joint. It's not a perfect hinge like something you get out of the hardware store. It's got rotational components and side-to-side components to make it functional. The joint here, again, is a resurfacing. We take that metal component, take out all that cartilage that's damaged, and resurface the joint with that polyethylene bearing. It's like a plastic bearing, and that acts as our cartilaginous junction. This is what a total hip and a total knee look like on the x-ray, okay? You can see the normal or pseudo-normal side, and then you see that white prosthetic in there. We essentially replace that surface, okay? And that's the same thing in the shoulder. So we can resurface, pretty much any joint. The knees and the hips have been around for a really long time. We have great success rate. Total knees are typically lasting 15 to 20 years. Total hips, 20 plus years, and total shoulders, they're a little bit newer and about 15 years on average, okay? They don't last forever. They're mechanical joints. Just like your normal knee wore out, just like the tires wear out, the joint can wear out over time, and that can lead to secondary surgery, or what we call revision surgery, in the future. So if you get to that point, see your medical doctor. You're going to need a workup. If you decided on joint replacement, he'll check your heart, your lungs, send you to a cardiologist if he deems it necessary. Make sure your dental work is up to date, because that first 3 to 6 months, we don't really want dental work done. Unfortunately, our mouths have a lot of bacteria on it. You'll also be taking a prophylactic antibiotic for dental work after you have your joint replacement. Prepare your home. I mean, you're going to be walking with a walker for a while, for the first week or so. Then you go to a cane, and then you go to nothing at all. Make sure you have wide open spaces, because the last thing we want is you go through a successful surgery and God forbid you fall and something happens in your home. You'll attend a preoperative class if you decide to do it here or most hospitals, where you'll learn about what to expect. The more you know going in, the wider open your eyes are, the better you're going to do. Because my job would be done in about 45 minutes to an hour. That's how long it takes us to do these joint replacements. After that, it's up to you to get that motion back and get the best possible result. Get help at home. That first week at home, you're going to need some help pretty much around the clock. After that, most people are doing quite well and can get by with just some intermittent assistance. Typically, surgery is in the hospital 1 or 2 days. This is, significantly different than it was even a few years ago. Here at St. Luke's, we're transitioning to same-day joint replacement surgery. They can be done in outpatient centers, in the surgery centers going forward. And that's kind of the future of joint replacement. Again, depending on the person, your comorbidities, meaning, heart disease, diabetes, all of these things need to be controlled as well. You go to outpatient physical therapy after that first week of home PT. The full recovery is about 8 weeks, and that's even stretching it. People are doing really, really well, much faster than that. But again, that's a good guideline. You follow with the surgeon at 2 weeks, you check the wound, and then 10 weeks later. As soon as you're feeling good, you can return to your low impact activities. So it's a pretty quick turnaround, especially if you've been suffering and limping around for a number of years. A lot of people say, what did I wait for? Potential complications. Anytime you go to the surgical suite, there's a potential for problems, okay? Thank God they're very rare. The biggest one and most worrisome would be infection, okay? An infection in the total joint is disastrous in certain aspects. Now, as the orthopedic surgeon, the hospital, we do everything possible to prevent infection. During the surgery, I wear a special spacesuit with isolated air. We do everything sterilely, of course. We clean your skin. We're going to have you swab your nose to check for any potential colonization of bacteria and treat that preoperatively. We're going to maximize your condition by keeping your weight down, keeping your diabetes under control. But again, these things unfortunately can happen and they have to be treated afterwards. Blood clots while you're asleep or early on when you're not moving as well are a definite worry. We'll have pumps on your legs during and after the surgery. We'll put you on a blood thinner. Depending on your surgeon, it'll vary from aspirin to injectables called Lovenox or some of the other blood thinners on the market. Down the road, implant loosening or breakage, even intraoperatively fracturing the bone. As we get older, our bone becomes weak and osteoporotic, and it's super rare, but things like this can happen. And then the implant life expectancy we spoke about before. What's new? The nice part of orthopedics, we're consistently changing and trying to improve our techniques. By improving our techniques, our approaches, we can hopefully increase longevity of the joint, and then people benefit from that. Quadriceps sparing knee approach. It's been around for many years. In this case, we kind of leave the tendon alone and do a muscle clipping approach. So the scarring's less and in theory, earlier range of motion at that knee. We do partial knee replacements. If it's a post-traumatic injury, you had a car accident and only 1 of the 3 areas of your joint are damaged, we can go ahead and just replace that. That'll allow for that bone to stay in place, and down the road, you may have to convert to a full knee, but in the younger people, that's a really good option, and sometimes in the very old, it's a good option. Anterior approach hip replacement. This is something I've been doing for the last 5 or 6 years. The benefit being it's a muscle sparing approach where you don't have to take down any of the musculature. it's a little bit more limited approach, so it's a little bit more difficult, and it's used on a certain subset of people. There are about 10 different approaches to the hip. The old saying, there's more than one way to skin a cat, and you rely on your orthopedic surgeon's, experience and his recommendation for that. One of the newer developments over the last 10 years or so is the reverse total shoulder. Our standard total shoulder relies on our rotator cuff to be in place. When we do have torn rotator cuff issues, in the past we had very few good options. This reverse total shoulder essentially allows us to flip our joint around, put our cup where the ball is and the ball where the cup is, and that allows us to use other muscles to allow us to get motion, okay? Again, these will all be brought up to you with your orthopedic surgeon, depending on your particular instance and problem. So most important, get a diagnosis, okay? Go see the doctor, see what's wrong. Not everything that causes knee pain is osteoarthritis or rheumatoid arthritis. Number two, conservative treatment. There's the nutraceuticals are out there. There's a whole branch of natural medicines that can work as anti-inflammatories. The arthritis can be managed with that combination of the medication, the weight loss, the activity modification, and then eventually injections and at some point joint replacement. Follow up with your orthopedic surgeon, see a regular doctor, and keep your other medical conditions under control. That's a big cause of our perioperative complications, the diabetes, weight. So the healthier you are going in, the better chance of avoiding complications and having the best possible result.